Andre, is that a common practice to use Ozurdex?
No, it's just cases of doing it under protocol studies, so you have to do that in order to understand if it's available or not.
And what do you do differently now, based on this experience, if you have to inject Ozurdex in a vitrectomized eye?
Well, if you're during the surgery, I think you have to do very slowly to avoid the Ozurdex hit the retina with a high velocity. And you have to put some kind of instrument, light pipe or something, just to hold the Ozurdex in order to reduce the velocity.
And I think you were just doing that, and I think it
exactly, but didn't work. So you have to be more carefully. As you see there, the Ozurdex was very fast, and I couldn't hold that. So yes, I tried to do that. And I had a case that I didn't do it, and the patient really had the retinal detachment because I didn't saw it. During the procedure, they finished the case, I used the Ozurdex, and a few days later, the patient had a retinal detachment. I didn't understand why he had a retinal detachment. I thought it was a vitrectomy-related tear, but actually it was related to the Ozurdex.
I mean, that makes a great point that when you inject, not only inspect the tip where the Ozurdex is coming out, but also the impact point, and inspect that area carefully to make sure there is no break. But question for you, what about the pressure on the Ozurdex? Isn't it like if you press it slowly on that button, that will decrease the impact?
Regardless, it comes with the same speed. It comes with the same speed, regardless if you inject slowly or not.
Yes, you have to pay attention on the position of the tip, because in vitrectomized eye in your office, if you may hit the macula area, so you have to direct the Ozurdex to the periphery.
Any comments regarding dislodgement of Ozurdex into the anterior chamber? Anybody in the panel have experience with that? Andre, I think you have experience with that.
Yes, I have one or two cases. You have to remove that on the same day, otherwise you may have a corneal edema, which is very terrible. Patients end up with corneal transplantation. And you don't put it back in the eye, you have to remove it completely.
So if you have an anterior chamber dislodged Ozurdex, it's critical, it's almost an urgent or emergency. Usually in ophthalmology, we do not have emergency, so it's an urgent surgical matter that needs to be removed immediately due to the toxic effect on the corneal endothelium. Is that correct?
Exactly. You cannot leave this Ozurdex more than 1 or 2 days.
And Kazuki, you also have experience on when we do air fluid exchange after oil removal. You know, when we have, and that jet flow of the fluid that can cause iatrogenic retinal break, just the flow. Can you comment on that for the audience?
Yes, and it is very dangerous to use IOP control during fluid gas exchange, such as an exchange in the silicone oil. So at that time, we take care of stopping the IOP control to avoid jet stream of BSS into the posterior pole.
So one of the ways when you do remove the silicone oil to get rid of those residual silicone oil bubbles is to do multiple air fluid exchanges. And then what you do is you let those basically this residual oil as a sliver over that fluid, and you go after that and remove it. And then you do that 2 or 3 times. But one of the things that can happen, as Kazuki, if the IOP control in the machine is on, sometimes during that exchange, you may get a very fast jet of infusion that itself is powerful enough to induce a iatrogenic break. And because it's fluid injecting, usually you get also a detachment that at that point needs to be fixed. Carl?
But Alcon anticipated this, and the IOP control kicks in only after 15 seconds after the switch to fluid. So it didn't used to be like that in the first, after the upgrades of the software. So the IOP control will not go right away. Only after 15 minutes, when the eye is already half full, then the IOP control will kick in.
During the air fluid exchange?
Yeah. So it's much more safe, and the stream will go into the BSS.
But that is one additional thing to pay attention for when you do the air fluid exchange. And one other option is not to do a complete air fluid exchange during those. You may want to leave the eye about 1/3 fluid in, so when that jet flow of the infusion comes in, hits the fluid level instead of hitting the retina directly. Any final word of wisdom on this topic, Hugo?
No, I think it's...
You agree?
I agree.